Hello everybody and welcome back to the lecture. Today we have a lecture of aesthetic analysis and especially about facial analysis. We try to follow a kind of systematic clinical approach in order to be able to really fix the problem of the patient that you have in front of you. So let me start with this kind of aesthetic analysis. That is the first step, as we said already. And of course, when you talk about aesthetics, we start with the face of the patient. So the face analysis will come as first. After the face analysis, then we start to have the dentolabial analysis. We are getting closer to the target, to the dentolabial analysis, and then to phonetic analysis. And only after that, we try to really be close to the teeth and to the gingiva. It means with the gingival and dental analysis. That's more or less our goal, that to achieve this kind of result. So let me start to say, when you look at the patient today, normally we look at the aesthetic parameters only looking the 6 anteriors. That is quite crazy, I believe, because normally we have the entire mouth to be restored most of the time, especially with the extensive rehabilitation. And I really don't believe that only the 6 upper anterior are needed to be really optimized 100% without taking care about the others. So, as I said already, we start with the facial analysis, and then we go to dentolabial analysis. And many times you have a situation like this in which the patient in front of you has a low smile line. So many times we do the treatment plan for ourselves. It means that we open the mouth of the patient with the retractors, and we see maybe the situation between the right and left. There is no specularity, no symmetry in terms of gingival outline. And we have an uneven gingival outline that we would like to fix it. But maybe the patient is not really absolutely ready to do this kind of surgical or orthodontic procedure in order to optimize the level, because it doesn't show, like in this case. So if you explain the patient before starting to work on patient itself, you start to say, look, you have lost my line. Do you care if you have some misalignment of the gingival outline? And the patient can say yes, can they say not? Of course, everybody, the first day of the delivery, they show themselves, the work that is done in front of the mirror. For sure, they try to see, is perfect or is not perfect. Of course, if they understand that it's not perfect, only at the day of delivery, it will be wrong. We should talk to the patient in advance, explaining exactly what you would want to do. Because if there is no any biological reason why we should analyze and optimize then the gingival outline, you have to consider that having the chance to optimize the level as some kind of steps. First of all, could be maybe a surgical procedure or orthodontic procedure in order to optimize the level. Secondly, it takes more time, you spend more, it may be suffer a little bit more. So consider all the time the chance also to leave as it is, the gingival outline, because if the patient is like that, with lost my line, maybe he doesn't deserve any kind of either other treatment. Of course, everything changed if the smile line from low smile line become average smile line. At this point, you show more than 75% of the teeth and, of course, all the papilla areas. So that's very important. Not to say what happens when you have the high smile line, or even more, the gum smile line. In these conditions, of course, you have the chance to say that will be absolutely a must, that to optimize 100% gingival outline. So let me analyze the face in 2 parts, frontal view and lateral view. And let me give to you some prosthetic consideration for aesthetic rehabilitation. So on the frontal view, we have some horizontal reference lines and a vertical reference line. We try to start with this, okay? And we start to say, let me start with the frontal view, with the facial analysis, and with the chance to check the harmonic relationship between horizon and the so-called reference horizontal line. So-called because sometimes they are not really parallel each other, like you see in this drawing, or in this one. So the interpupillary line is normally taken as the horizontal plane of reference. But remember that many times we have not the situation that is really horizontal to the horizon, parallel to the horizon. So the horizontal in this case is taken as an ideal reference plane. Regardless, the interpupillary line and the commissural line are aligned or not with it. So you have to check all